Okay, whew, man, I don't know. All right, here we go. The sensory homunculus, that's kind of a funny word, I think, that refers to this functional map of the sensory areas of the brain. And we've already talked about the fact that the front part of the brain is the motor, and the back part behind the central or the lateral sulcus there, or central sulcus, I guess it's called, is the sensory. And this little drawing, this little homunculus, is kind of a map that sort of relates things to how much area of the brain is taken up by it. And so this is for sensation, and we have a lot of, I think I've talked about this, we have a lot of sensation in our tongue and in our jaw and in our lips and in our face and in our fingers. We have this area that covers our arm and all our body and toes and even genitalia is pretty small compared to the tongue and the face. And just as a reminder, somebody asked me the other day about where does the crossing over occur? You know, because we've always said the right side of the brain controls the left side of the body and back and forth. Well, here we are. This is for sensation. This is sensory. So here's the input coming in. The fine motor input comes into the spinal cord at whatever level you're at. Its first nucleus is right there in the dorsal root ganglion. Remember, this axon here goes all the way down to the toe or the finger or wherever. Very long axons. Here's the body. It comes in. It goes into the spinal cord at this level, and then it goes up to the nucleus gracilis up in the medulla, right? And at the medulla, that's where it crosses over. So it crosses over in the medulla from the one side to the other side. Then it comes on up through the mesencephalon and goes up to the ventral nuclei and the thalamus. And remember, almost all sensory input into our brain has a way stop in the thalamus. So that's what this is. And then this is the third nerve in the chain. So this is a first order neuron, second order neuron, third order neuron, which actually takes the information up to the brain. And that's this column here in the spinal cord is called a posterior column. Because remember, if you take the spinal cord and put a line right across the middle of it, everything on the upside is sensory, and everything on the downside is motor. So not only is it sensory on this part of the gray matter, but it's also sensory on these parts of the white matter, and here they go up to the brain. They cross over at the level of the medulla. That's the thing you probably ought to know. So what's the point? Well, the point is that every area of your body on the outside has its own corresponding area of the brain. In other words, we don't touch our finger and then it decides where it wants to go in the brain. It goes to a very specific point that has always been accurately reflecting the sensations coming from that small, tiny area of the brain. Why are different things different sizes? Well, you remember that thing we talked about with those circles that were different sizes? What do we call those? Receptive fields. Very good. So, which areas would you like to think you could feel with the most accuracy? Well, let's face it. Our fingertips, our lips, our jaws. Those things are really important because they really influence us talking and being able to manipulate and so forth. Now let's stop for just a second and think about this for a second. What areas, we're going to have a motor homunculus in a minute, okay? The motor homunculus, there's different areas of the motor strip of the brain that control different things out here, right? And what do you think is going to be the biggest parts of the body in terms of the motor homunculus? Just think on it a minute. A couple things you ought to know about it. One's called referred pain, feeling pain. How do we feel pain? Well, yes, I feel your pain. What's referred pain? Well, you know that people that have heart attacks frequently feel that as either pain in their left shoulder or in their chest, sometimes even in their upper abdomen. A lot of times it's classic for a heart attack if they have pain in their jaw. If they're having really bad pain and it's coming from their jaw, that is a heart attack, just so you know. In fact, in women, that's probably more common. But you've always heard of it. It goes down the left arm, and that's a business of referring the pain to another area. Well, why is it referred? Well, a lot of it we don't really know. Appendicitis is a tricky one. I probably lost more nights sleep and more hours in the emergency room with abdominal pain than anything else, because they would always call the surgeon and say, well, he's got a bellyache, what's going on? And you had to come in and examine the patient, and you realized just how poorly our sensory pathways of the brain helped us localize things. Especially appendicitis, it usually started around the belly, and then 12 hours later, maybe it started to work the way down in the right lower quadrant, and then eventually it got bad, and they would have a little guarding, a little rebound, and then you'd say, well, it must be appendicitis. At least I feel strong enough that it's appendicitis that we ought to operate on it. Even though we weren't right all the time, it was okay, because you didn't want to wait around until they ruptured either. So it's always kind of a crapshoot. Here's several examples of referred pain. Gallbladder pain is really classic. I remember any time a lady came into my office and I would say, well, ma'am, where's the pain? And she says, well, it's right back here. It was her gallbladder every time. That's just where the gallbladder hurts. And of course, gallbladder disease is a disease more of women than men, although it occurs in men as well. It can occur up to the shoulder, as illustrated in this picture, but I think much more frequently it goes straight through into the back, even more so than that picture. Here's that heart thing I was telling you about going down the left arm. The ureters, if you have a kidney stone and one of your ureters is blocked off, most men will tell you the pain is in their testicles. The pain radiates right down here because the nerves that go to your ureters here, your ureters are being blocked, so they're stretching with ongoing, keep making urine. They stretch, and that's what causes the pain. The pain radiates right down in through here. It does in women too. It radiates into their labia majora, but in men, they always think it's their testicle, and it's not. You can tell that by checking their testicle, and that doesn't seem to hurt you at all. Well, it doesn't, but that's where the pain feels like it's coming from. Remember we talked about the interoceptors, about the sensory. We didn't have very many interoceptors that told us about pain in our internal organs, our viscera. This picture, I think, describes that pretty well. Colon is kind of all over. Appendix is all over. Small intestine, stomach. We just don't know how to localize where the pain is coming from, if it's coming from one of our inner organs. Why? Because we usually never feel pain from there, and even then we can't localize it. Now we've talked a lot about the proprioceptive fibers and helping us figure out where our joints and stuff are. The spinocerebellar pathway, that's one you ought to know, I think. It carries information from the spine and from the extremities down here. Carries all this proprioceptive input up here about where the position of your skeletal muscles, the tendons, the joints, it tells about them. So here's what it looks like, and please, you don't have to memorize every bit of this, but I think it's important that we give you a couple of 2 or 3 kind of examples of how nerve information is carried from the periphery all the way up to the brain. In this case, does it really go all the way to your brain, to your cerebrum? Not so much. Where does all your proprioceptive stuff go? It goes to your cerebellum, up to your pons and up to your cerebellum, and that's what's going to help you maintain balance and things like that. So here it is. Here's proprioceptive fibers coming up here in through the dorsal root ganglion, and then come out here into the spinal cord, they synapse, and they stay on the same side, and they go up, 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 up through the spinocerebellar pathway. Once again, it's white matter. It's sensory, so it's on the upper part of the. This one almost looks like it's more out lateral, but it's still up. And it goes up to the pons, and the pons then puts it up into the cerebellum. Now, remember, we don't really think about what happens in our cerebellum much. Our cerebellum just coordinates all our movements and allows us to move things appropriately. So there's another one. Just two cells, a first order neuron and a second order neuron. I think I've made this point several times already. Almost all of our sensory information goes through the thalamus before it gets to the brain. Small fraction is all it really makes it up to the cerebrum and then reaches our awareness. I've already said this too about interoceptors. These are the ones that monitor our visceral tissues. Intero is internal, visceral, in the abdominal pelvic cavities. We're not very good at them. Cranial nerves, 5, 7, 9, and 10. Let's think about those for a minute. 5, what's it called? Trigeminal goes to the face and some into the mouth, right? 7, 9, glossopharyngeal, 10, vagus, right? Keep those in mind. So they carry all this visceral information from your mouth, palate, pharynx, larynx, trachea, esophagus, and associated glands and so forth. They carry it up to your brain so you can feel it. All right, now we're going to talk about the muscles a little bit more because this is the autonomic visceral motor system. This is the one that goes to all of the things that are out of your control. When we say autonomic, you should think automatic. The system that works automatically without you having to think about it. The smooth muscle, the cardiac muscle, the glands, all your guts and everything are in this group we're going to be talking about here. There's always an upper motor neuron. We're into motor neurons here. We're always talking about an upper motor neuron and a lower motor neuron. And a single nerve always innervates a single motor unit. Remember motor units from back in 231, where there would be one nerve comes down and it innervates 3 or 4 or 100 motor units, motor fibers, muscles. And then remember, one motor unit might get tired and the next one would work for a while and that one would relax so that we can maintain constant pressure on things. Let me tell you, if you don't have the lower motor neuron, if you don't have that nerve that's going into this muscle, this lower one, nothing's going to happen. You're going to be completely paralyzed. Okay? It's going to be a flaccid muscle that does not react at all. Now, the signal that came to that came through the first order neuron, which came down from your brain, and that's what we call the upper motor neuron. And that upper motor neuron may do one of two things. It may either inhibit the input to a muscle, or it may make it overactive. And you've all seen people in your life that are spastic, and they can't control things, and they're moving everything around. And a lot of that is because of upper motor neuron problems. I think I have some videos to show you later. So, I guess the thing that I would want you to remember is that the lower motor neuron, the cell body of that lies up in the brainstem or in the spinal cord, and it triggers the contraction of that innervated muscle. It's the one that makes the muscle contract, and it came all the way from your brainstem or your spinal cord. If the problem is with the lower motor neuron, then there is no control whatsoever. If you can't get the last neurons work, worth, you have no control over anything, and that muscle is paralyzed. Quickly talk about the corticospinal. Corticospinal, what does that sound like that ought to do? Going from the cortex to the spine. This is a muscle motor pathway. So this is truly the muscle tracts that you use to tell your finger to contract. Okay. This is the voluntary, under your own control muscle system, also called the pyramidal system. Provides voluntary control over skeletal muscle. They all start up in the primary motor cortex. Wait a minute, where's the primary motor cortex? Front, right? Front seat, primary motor cortex. They go down into the brain stem, and that's where in the brain stem is where they synapse with these lower motor neurons that are going to take the message all the way on down to the muscle. There's several names for them. I don't hold you to these. Just know that these are on their way carrying messages down. Now, let's talk about the motor homunculus for a while. I asked you, what was probably the biggest area? Anybody just think about where you need more motor input than anywhere else? Your hands, that's a good guess, but not exactly right. What? Your eyes? No, not exactly. Well, think about me talking and singing. Hello, now I'm talking and I'm oh. We have an incredible amount of motor control on those two vocal cords. We have as much motor input to our vocal cords to allow us to talk as we have to lots of our body. And if you think about how complex making noises and saying words just by having two chords there, you ever taken a piece of paper and you hold it tight and you blow on it, it makes a noise. Well, that's how we make sound. And in order to do that, we have to have incredible control over our vocal cords in order to make noise. So, here you have it right here. The larynx is by far and away the biggest. The tongue is next. And then you do have some fingers and so forth. But notice there's very little motor control, or not near as many motor fibers or as much area of your brain involved in the lower parts of your body. When you think about athletes, I don't know. They have a lot of control over their body, but still, those muscle units are pretty big usually. So here's just look at this and think about this with me. If you want to send a message down to the body somewhere to some skeletal muscle, it's going to come from the cortex, from your brain. It's going to go down through the corticobulbar tract, down through the cerebral pedicle, into the medulla oblongata, and then it's going to come down here in the lower part of the medulla oblongata at the pyramids. That's where the crossover is going to occur in the motor system. Remember, actually, didn't the sensory system cross over in the medulla as well? Yeah, it does. So then it goes on down. It goes down through the lateral corticospinal tract. It's on the motor side, so it's on the front half of the spinal cord. It gets down here into the proper level for the control of that particular muscle, and sends and hooks up to a nerve cell body here in the motor part of the gray matter of the spinal cord, and sends the message out, which then goes out through the ventral root. Remember, the ventral root is all motor to where it's going. Well, the areas of your body that need the most fine motor control we've talked about. And this is something I think you just need to go home and appreciate how incredible your larynx is. We're going to get to the larynx here soon. But, in order to create every letter in the alphabet and at different volumes and at different ranges of sound is pretty amazing. How much control we have over those two vocal cords. Cerebellum, I think we've talked about the cerebellum a fair amount. I think you know that it's mainly position sensations, but the cerebellum also combines other information like from your eyes, your balance, and the perfect example is the Romberg test, which is this one here, where you just have a patient stand there with his arms out to the side, and most patients can stand pretty still, but if you have them close their eyes, then they'll tend to waver a little bit more, and that's just because the cerebellum has given up that visual input to help with your balance. So why do we sway less with our eyes open? Because when we have our eyes open, we have all that additional information going in there to help us. Let me talk to you real quickly about neural tube defects. This is from my pathophys course. This is not really a big deal. I talked about the nerve tissue, the ectoderm, when it forms, it loops around and wraps around the brain. This is the example of the 4 different layers of 4 different levels of this disorder. The lowest one down here is really called spina bifida. You notice that the skin is kind of over it here. This is the spinal cord. Notice that the dura is still intact and it's sitting there, but the back part of the vertebral arch isn't completed, so therefore the back part of the spine down there is injurable. The next step is when it does, not only does it not cover over, but the spinal column sticks out under the skin, and these babies are born with a big bulge on their back, but at least their skin is intact over here. The next one, this is called a meningomyelocele, because the meninges and the spinal cord itself are sticking out of their back. This is a really tough deal because these kids are all paralyzed from this level down, usually in the lower back. And then this is where the neural tissue really didn't close over at all, and that goes all the way up. So that's where you get the anencephalic babies that I talked to you about a little bit, where we got the kidney transplant. This is an anencephalic baby right here. This is a meningomyelocele. We used to see one of these every week or two at Children's Hospital up in Washington, D.C. I would like to think that these aren't as common anymore because ladies are taking their folic acid. Folic acid is a vitamin that's very, very important early in pregnancy. The problem is most women, by the time they realize they're pregnant, it's too late. So my advice to any of you who are even thinking about ever getting pregnant, start taking your folic acid that day. Because if you ever get pregnant, by the time you really know you're pregnant, it'll be too late. And folic acid will really prevent a lot of problems like this. This is hydrocephalus. Somebody in the class, I believe here, has a child with hydrocephaly. This is one that obviously didn't end up well. This person died, obviously. But the ventricles, you see how huge they are because the CSF was forming, but it couldn't get out. These days, what we do is the neurosurgeons make a little bitty hole in the skull up here, and through that stick a needle in that has a plastic tube on the end of it. It's actually silicone, and they bring that, stick it down here into the brain, comes out through here, out through the hole in the skull, and then underneath the skin, and it's passed underneath the skin all the way down into the abdomen. And then it has a little flutter valve on it that allows the fluid to flow in one direction, but doesn't allow it to go back the other way. And these can be treated so that they never get this big at all. And if they don't ever get big and huge, then these kids can be pretty darn normal. My experience back in the 70s with pediatric surgery and these sort of things was these kids were back a bunch. You know, they might do great for 6 months, and then their shunt would quit working, and then have to get another one or get it changed or something. They'd clot off or something. This is an example of a brain injury. This is a stroke, and you can see this brain is the same as this one. They sliced it down through here, and this is a stroke, a cerebrovascular accident, CVA. This is what we call an ischemic stroke, and what that means is that one of the artery, which is probably the middle cerebral artery, was blocked off, and so this area here didn't get blood for a while, and it's dying here, or it's dead here. What deficit do you think that patient would have? Well, let's see. It's in the front. Here's the central, isn't it? Maybe it's this one here. Well, it's on the right side, so the defect would be on the left, the patient's left, right? And I'm going to say it's behind the sulcus here. So if it's behind, that would be sensory. That patient would certainly be numb. And usually when patients have an area of brain that's this big, it causes a lot of swelling, and the swelling in one region of the brain causes pressure on the entire brain, because remember, the brain lives in a box that can't get bigger. So when things in there swell, it causes high intracranial pressure and gives them all kinds of troubles. This is probably the most common cause of strokes, is caused by narrowings in the carotid artery. Atherosclerotic plaque forms. This is cholesterol. That cholesterol can then have little clots form on it, and when those clots break off, they go up to the brain. If it's a small one, it just lasts a few minutes usually, and we call it a TIA, a transient ischemic attack. Usually the patients make a full recovery. But if you ever have a TIA or see somebody have a TIA, it's very serious, because they need to go in and be evaluated and make sure they don't have a more serious narrowing like this that's close to completely clotting them off, because that usually leads to a very severe stroke, although sometimes even that doesn't lead to much of a stroke because of the circle of Willis up there. But anyway, we used to go in here and open this artery up, peel all that cholesterol out, sew it right back up, and I probably did 250 carotid endarterectomies, and I had 2 strokes out of 250 cases, so it was under 1%, and that's what you kind of want to shoot for with that operation. But you can really save these people having big-time strokes by cleaning their arteries out. You generally take them from about 95% narrowed off to 0% narrowed off by doing that operation, and they almost never get it back. Here's another. Here's another stroke over here in this part of the brain. You can see it on CT scan here. What's this right up here? Frontal sinuses. This is what baryaneurysms look like. This is what a ruptured aneurysm looks like. Basically, the aneurysms look like this, and when they bust, it's pretty fatal. Few people survive it. Those that do generally have big deficits. But it's kind of like, as you can see from over here, when one of these things breaks, it's like taking a fire hose and shooting it out into the jello of the brain. And these patients often die. This is the vertebral arteries coming up here. They meet to form the basilar artery. And then right up here is where you have your circle of Willis. Here's an angiogram of an aneurysm. Actually, this is 2. You see one big one here and one big one there. It's hard to imagine they don't bust. They have all kinds of fancy ways neurosurgeons do now of either clotting these off or clipping them off so that they don't bust. Here's what it looks like on the angio. Here's the other one on the angio right there. Angiography is a deal where you go in at the groin usually, put a little catheter up, set it up here in the carotid artery, squirt a bunch of dye in, and within the next 10 seconds after squirting that dye in, you take a whole bunch of pictures of the head, and it shows the blood flowing up into all the arteries and helping you figure out what's going on. This is Alzheimer's disease. Alzheimer's disease is a disease of the brain where the connections between brain cells don't hook up right, and these areas like this form, and when they can't make the connections, they can't think right. You know, I think it's as simple as that. This is multiple sclerosis, also a plaque disease that forms spots in the brain. Multiple sclerosis has a very variable clinical picture. Some people get a little episode of multiple sclerosis, it clears up and goes away and never comes back. Some people get it and it gets worse and worse and worse and worse and can actually kill them. Okay, that's the end of it. I think I'm going to wait till we get over to lab to try to make that, to show you the YouTube videos, because I've been struggling with this computer, as you noticed.